Preventing hip osteoarthritis. Is that really possible? Thank you for joining me. Here's the relationship between X-ray and pain. Studies show that approximately 20% of hips with radiographic evidence of Hip OA are frequently painful. That means 80% of Hip OA that are seen on X-rays are not painful, meaning that 4 out of 5 patients with signs of Hip OA have no significant hip symptoms. There's approximately a 10% risk of needing a total hip arthroplasty, or THA, during the course of a person's life. That's 1 in 10 of us. Can we really reduce the risk of developing painful Hip OA or ever needing a total hip arthroplasty? In this short presentation, I'll cover the potential role of the following factors in the development and the prevention of Hip OA. Hip dysplasia, genetics, diabetes, body mass index, cholesterol, diet, femoral acetabular impingement or FAI, pharmacological interventions, and physical activity. So let's get started. First, let's talk about hip dysplasia and Hip OA. There's a positive association between hip dysplasia and Hip OA. Unfortunately, it doesn't look like we can do much about what happened to them during their childhood or when they were born. How about genetics? Well, longitudinal studies on twins show that genetic factors have a significant contributing factor to the development of Hip OA. However, that's not necessarily associated with pain, as we already know that 2 individuals can have identical looking X-rays. One can run 5K and the other needs a cane to walk. So, although genetics does play a role, it's not the whole thing. How about diabetes? Well, type 2 diabetes doubles the risk of undergoing a total hip arthroplasty. Type 2 diabetes predicts the development of severe osteoarthritis independent of age and body mass index. How about body mass index and Hip OA? Well, although obesity is a strong risk factor for the development of knee OA, the association is much less for hip osteoarthritis. There are to date no studies to support that losing weight reduces the occurrence of Hip OA. The truth is that being overweight or obese increases the risk of developing even hand osteoarthritis. Perhaps it's not about the weight itself, but about the systemic inflammation associated with obesity and inactivity. What about cholesterol and hip osteoarthritis? Well, a strong association between OA and raised serum cholesterol together with clinical effects in statin users suggests that potential benefit of reduction of cholesterol by dietary means. However, it must be said, I don't believe it's the cholesterol levels that are causing the osteoarthritis. It's just that high cholesterol levels normally indicate inflammatory agents present in the body or low-grade systemic inflammation. What about diet and hip osteoarthritis? It suggested that greater ingestion of fiber could reduce symptoms related to OA by having an effect on microbiota in the GI system and reducing low-grade inflammation in the body. So what's suggested is that having fruits and vegetables in a diet, or increasing the dosage of that at least, could reduce the low-grade inflammation, which could be a contributing factor to arthritis anywhere in the body, including the hip. What about pharmacological treatments and Hip OA? Well, to date, no pharmacological treatments such as NSAIDs or supplements, including glucosamine or chondroitin, have demonstrated to help prevent OA in any part of the body. What about femoral acetabular impingement, or FAI, in Hip OA? As you can see in the image, you can have a cam deformity or a pincer deformity. The association between FAI and Hip OA is still undetermined, as radiographic evidence of moderate to severe FAI is common and often without any sign of Hip OA. Current evidence does not support prophylactic surgery for asymptomatic FAI. If you could only prevent future OA by doing surgeries on FAI, if you had evidence of it, it would be there by now. What about trauma in Hip OA? A systematic review found that the risk factor of Hip OA multiplied by 5 after a local trauma to the hip in both the senior and the young athletic population. Approximately 12% of the overall prevalence of symptomatic OA is attributable to post-traumatic OA of the hip. Perhaps balance training and fall prevention measures could help reduce the risk of hip trauma in the senior population, as falls resulting in fracture is a high risk factor for development of osteoarthritis later. And perhaps appropriate training and warm-up may reduce the risk of soft tissue injuries in the young athletic population. Although warm-up and exercising has been shown to reduce the risk of knee injury in the athletic population, this hasn't been demonstrated in the hip condition just because the studies haven't yet been done. What about physical activity and hip OA? Moderate physical activity is not associated with greater risk of hip OA. In fact, running is associated with a reduction in the developing of symptomatic hip OA. Running significantly reduces OA and hip replacement risk. A typical patient who goes to their MD and says, "Doc, I got knee pain or hip pain." And the doctor asks, "So when do you get it?" He says, "Well, when I run." Well, they say, "Well, don't run anymore. It's bad for your knees or bad for your hips." And I'm going to say, if they say that, what a bunch of nonsense. Again, the systematic reviews support that running significantly reduces OA and hip replacement risk. Can we really reduce the risk of developing painful hip OA or ever needing a total hip arthroplasty? Perhaps. The prevention of hip OA depends mainly on preventing overweight and obesity and promoting physical activity while avoiding joint trauma using joint warm-up programs. And that's a quote from a latest study published in 2020 titled, "Is Hip Osteoarthritis Preventable?" So which one of these risk factors can we actually influence? Well, dysplasia, unfortunately, we can't influence. Genetics, unfortunately, we can't influence either. Diabetes, to some degree, development of type 2 diabetes could be prevented, again, but it's based on genetics also. How about BMI? To some degree, it can be controlled. How about cholesterol levels? Again, there's a genetic factor to it, but to some degree, it can be controlled by physical activity and diet modification. What about diet? It can be modified. And what about femoral acetabular impingement? Unfortunately, we don't know how to modify that. And what about pharmacological interventions? They don't seem to make a difference, so there's nothing to modify. What about physical activity? Yes, of course we can modify that. Did you find this information valuable? Join me at my hip osteoarthritis course where we discuss the only factor that we can influence in preventing hip OA, physical activity. We will review evaluation and functional exercises for the management and the potential prevention of hip osteoarthritis. It's important to note that I will not be teaching bridging, hip abduction and side lying, or clam exercises, or anything of that sort for that matter. I look forward to seeing you. Thank you for joining me.